Welcome to another episode of The Granite List Live, where we explore all things human capital and employee benefits related. I'm your host, Sally Pace, and today we are joined by the illustrious Dr. Cristin Dickerson, founder and CEO of Green Imaging. Thank you for being on the show today.
Excited to talk to you as always, Sally.
Absolutely. Well, I want to start, we at the Granite List are very familiar with Green Imaging, but I hope we've got a handful of listeners out there that this is the first time they're hearing about the organization. So do you mind starting with just a broad level history of what led you to found Green Imaging?
Sure. I had the problem in my community that most people have in their community right now, almost 15 years ago, which there wasn't affordable imaging. My friends would call from the hospital and say, hey, do I really have to pay $1,500, $2,000 for this MRI? And at that point in time, they really did, because the chain of imaging centers that had been in network was bought by a hospital system, and overnight the prices tripled. I have a friend who called last week, and the orthopedic practice she's gone to for forever, she's actually married to a radiologist. That orthopedic practice, she's always just paid for an MRI there, $400-ish. It was actually $2,300. And so she called me immediately and said, Cristin, where can I go? And so, that's a ubiquitous problem in our country right now. And as private equity's been buying up the imaging chains, hospitals have been, and then they're combining them and using good old contracts and driving up the cost. And so I was running a radiology group. We were reading for facilities that were having to operate out of network because the in-network reimbursement was so low, they couldn't keep the doors open. And they were at 50% capacity. So instead of just building another imaging center where I would be in the same boat, I got the idea Travelocity and a lot of those not brick and mortar alternatives, markets were evolving. Got the idea, and it turns out under the Stark laws, which regulate physician referrals, it was legal. And we did lease arrangements with these facilities, bought the unused time on the table at these imaging centers, pushed it to our PAC system. We're radiologists. I had a great radiologist, still do have a great radiology group. We read the study and we bill one price for that exam.
When you're working with these facilities, is it any imaging service? Kind of layman's terms for those of us that may not be familiar with all the different imaging options available.
Well, we've actually expanded it beyond imaging, so that's a really great question. But imaging is typically X-ray, ultrasound, DEXA, which is bone density assessment, mammography, MRI, CT, PET-CT, nuclear medicine studies. That's traditional radiology. Even going into the cardiology imaging space, where echocardiography, some of the nuclear studies now emerging are great MRI techniques and CTA techniques for the heart. Those are some of the super expensive exams now. But we, at our client's request, we've added additional testing. So a lot of times that order has an EMG, an EEG, a sleep study, other exams ordered, colonoscopy, endoscopy. And so we have started adding those additional services. We're not going to veer into the surgery space, and these studies need to be correlated often. So, we've certainly added those services, and I think it's been very well received and very well utilized.
You're based in Texas, but what is your market reach?
Our market reach is now over 5,000 testing facilities in 50 states. And so what we really like to do with a potential new client is do a geo-analysis. We just need a de-identified census, and we look at where those members are, and we map it against our network, and we present both a bar graph and a map that shows where their members are. And if we need to build out the network further, we do. Especially with a lot of that high-end testing. There are only 2 facilities that are in the outpatient world in Houston, one of the biggest medical centers in the world, that do those coronary CTAs for the general public. And so we know where those are. And so we're able to go create bundles. If there's a city that doesn't have that, a smaller city, we go create a bundle with a hospital system. We get the facility fee included. We get the professional fees from the cardiologist. We get all of the costs in there bundled together, and we charge a single flat rate for that.
That actually leads me into my next question. Can you talk through what the value is for deploying your services both for the employer and the employee?
Absolutely. Right now, 50% of Americans are delaying care or going without care because they can't afford it. That is a terrible statistic. It's bad for employees and it's bad for employers. Employers have both, if there's a delayed diagnosis, they have dramatically increased costs. Back in 2016, this is not today when we've had so much inflation. In 2016, if you had an upstaging from a stage 1 breast cancer to a stage 2 breast cancer, it was over $100,000. That's not mentioning the time off work. That's not mentioning the disruption to the workforce of having often a young woman with breast cancer being treated. And really, I think if there weren't affordable options for employers, it would be different. But they really do have affordable options. Whether it's direct contracting with an imaging center down the street, which I can tell you why we're better than that, or it's using green imaging, they have a fiduciary duty. Employers have a fiduciary duty to provide affordable options. And when there are affordable options and they're not using it, there's starting to be a setup for a lawsuit. And we're seeing that happen across the country. And so I would say just more from an ethical standpoint and from a happy workforce and healthy workforce standpoint, they have that advantage. And then for the member, a lot of people go without exams because they can't figure out how to get it. If somebody told you you needed a HIDA scan with Kenevac, would you know where to go get that?
I wouldn't even be able to spell it.
Absolutely not. Or a coronary CTA, you call 20 imaging centers and they don't do it. People go without care because they don't know how to get it. And we've seen navigation, like your company is doing, be a partial solution to that. But we help with making sure they have access to exams. Right now, we have a school district in Florida. Most of the facilities there are booked out until late July for diagnostic mammograms. We're able, because I read for one of the facilities, so they don't have access issues for the radiologists, we're able to get those the next week. And so really, I think it's the access and the fact that the employers are offering this at a low cost or at zero out of pocket. The members benefit tremendously and don't have delayed diagnoses.
I want to go back to something you touched on earlier, and that is direct contracting versus your model. I think you and I both run in this similar circles where people are starting to learn about innovation, how to unbundle health plans. It's still very foreign to most consultants and benefits leaders. So talk through what those differences are between direct contracting and what you've brought to market.
In a perfect world, you could just go sign direct contracts in the cities where you have members and probably do really pretty well. The problem is that facilities are not always ethically aligned with employers. In fact, the system is so broken that they get paid a lot more for doing a more complex exam than for a less complex exam. And so if a CTA of the chest is ordered without and with contrast, the average imaging center is just going to do it that way. And with more and more secondary providers, they're less skilled at specific ordering. They're not like a specialty physician that knows what to order and what the best thing is to order. So frequently, they're just writing the most inclusive order they possibly can. At Green Imaging, we downcode about 30 to 35% of orders. And so there's savings in radiation, in contrast exposure, and in cost there. The other thing is if they're ordering the wrong study for this indication, if we should just be doing an ultrasound because that's going to give us the answer and not an MRI, we help with that. And so we're giving a lot of clinical help along the way. We're saving costs that way. Also, a lot of times the radiologists in an independent imaging center, they're owned by a radiologist. They may not have all the subspecialty care. And it is for some exams, I'm a general radiologist. I'm also a mammographer, but I'm a general radiologist. I can read a lot of studies. Do I want to read a meniscal tear in a 30-year-old athlete? No. Do I want to read MRI of the brain done for pediatric tracts and optic nerves? And no, thank you. If it's just rule out stroke, sure, I can do that. But a lot of exams require some clinical specialty and acumen that you just can't get in that setting. And then many imaging facilities now don't do mammography. Many don't do coronary CTA, cardiac MRI. And so to really have the gamut of imaging, you need more of a solution for your employees, not just, and I think a physician-centric solution where the employer ethics of the patient and ethics of the physicians are aligned. So we consider ourselves to be kind of the radiology equivalent of direct primary care.
I love that analogy. So let's transition a little bit and talk about the logistics of it all. If I'm an employer and I'm intrigued Am I bolting this on to a traditional medical plan? How does it get deployed within an employer population?
That depends. And we're really kind of agnostic. We need a guaranteed payer. But, the first question, if they're with an independent TPA, is, are you contracted with our TPA? Because that's an easy solution if we already have workflows and a contract with their TPA. More and more of the BUCAs, I'm hearing stories. We actually have one BUCA that's the UMR client that they're actually taking our claims. We'll see how that goes. But I think the trend with the BUCAs is going to acquire some independent TPAs that have experience with direct contracting and starting to try to compete in this space. I think they see the solution is on the wall. If you have a BUCA plan, though, and you just want to save your employees money, we can just be bolted on outside that plan. We can charge you, you pay us, and it's super simple, and it can happen next week. And so, there's a lot less coordination. So sometimes when people are in transition, they're going to move away from the BUCA plan. They're going to make all these changes, but they need direct primary care, imaging cost containment. The first step is just to contract with us outside the plan. And we can work with the stop loss carrier. And, if they're willing to take the aggregators, we can certainly provide that.
Part of the hallmark of what you've built is twofold: cost and quality. You have any statistics, or can you give tangible examples of what that means to a health plan or to an employer?
I'm going to say the first thing. I actually was at the DFW Business Group on Health last week, sat down at the table, and the head of HR for one of our clients said, I just want to tell you, and she said, Ebony, close your ears because I'm not advertising for her. But she said, what my members love is the compassion your team shows. And to me, really, if you look, even the American College of Radiology, what do people think quality is in imaging? It's how they're treated. It's how they're treated by the tech, how they're treated by the people who schedule them. That is the most important factor. Now, on the other hand, we guarantee our exams. So if a patient is not satisfied, if a referring physician is not satisfied, whatever happens, we guarantee our exams. We will say, okay, we'll get this done somewhere else, and we guarantee you will be satisfied. That has happened 7 times in 13 years. That, to me, speaks very highly. The other is we have 4.8 Google stars, despite the fact we're relocalizing care. We're telling somebody who already has an appointment down the hall at the hospital that we're going to go get that order for them, and they may have to drive a little further, but they're going to get this at zero out of pocket. They're real reviews. You can read. Sometimes things go wrong in healthcare, but most of them are glowing. The ease of use is really appreciated, and the compassion, and it shines through in those reviews as well.
Yeah. And I think that speaks to the heart of something you led with. Healthcare is so expensive. It's so confusing, and it's an unsustainable current trajectory. And so to be able to guide someone and explain to them why you're doing it to help save them unnecessary procedures, unnecessary spend is huge. And I know you've received a lot of accolades for what you've done. You've also been validated by the Validation Institute. Can you tell our audience who may not be familiar with that process what that was and what you were validated for?
Sure. Actually, we wrote a white paper on a client's experience with us, and what it was really, what they validated was our claims data assessment. So we talked about the geo assessment we like to do. If you do have access to your claims data, we can also extract all of the imaging costs. And when Aetna tells you you're spending 6% of your healthcare spend on imaging, don't believe them, because the interpretations, the professional fees are hidden over in the physician fees, and the radio tracers and contrast are hidden over in the HCPCS codes pharmaceuticals. And so we actually bring all of that spend together and compare what it would have been in our facilities, what the apples to apples comparison. There's still going to be soft savings, because if somebody goes down the hall at Mass General and has an MRI, they've met their deductible, and the health plan's going to pick everything up all year. If their employer offers it zero out of pocket, they're not even close to their deductible, and they didn't have a meniscus tear, and they're not going to touch their deductible. And so the employer has saved money on the cost of the exam, and the rest of the year is saving money on that. So there's soft savings as well. We typically save about, if there's not cost containment in place, we save about 60% on the imaging spend. If there's reference-based pricing, if there are other cost containments in place, we have to do calculations and figure out what their admin fees were that go away if they And that's a good point. We have no admin fees or PEPM, so there's no risk. But the Validation Institute validated our means, and it's a long white paper, and we're happy to share it, our means of assessing those claims and comparing them to what that would cost in our network.
And is that claims analysis, is that a fee? Like if I'm curious.
No, it's our best sales tool. We can show you what you're going to save.
Well, then I want to end on how would somebody go about taking you up on that offer?
Absolutely. We have support at greenimaging.net, goes to our business development team. So again, that's support at greenimaging, all one word, and it's .net, but you can just go to our website and communicate with us as well. That team will talk you through what we need for the claims data assessment, what we need for the geo assessment, just tell you a little bit about green imaging, provide some tools, show you the member experience. That team is really skilled at helping you understand how green imaging would work for your company.
Awesome. Well, thank you, Dr. Dickerson, for creating what you've created, for impacting the lives that you are in our country. We're so thrilled to have you as a partner at the Granite List. And I want to thank our audience for listening to another episode of the Granite List Live.
Thank you for listening to this episode of the Granite List Live. Access our entire library by visiting your favorite podcast venue or subscribe on our site, thegranitelist.live.